A lot of good stuff from the meeting today. Hopefully this final session will bring together all the principles that we've been talking about today. I think it would be nice to hear from everyone about their different philosophies. So overall, I was hoping that we're going to do 4 quick cases so we can actually ask each panelist their overall revision philosophy, where they get their zone of fixation, then some more specific cases with some challenges that we may face in clinic ourselves. All right. So I guess, Jeff, you're the first one up. So this is a patient from my clinic. It's a 52-year-old male, status post left uni 10 years ago, right uni 8 years ago. He felt a pop a few years ago, was told he had a fracture, had difficulty finding a doctor that took his insurance. His BMI is 46, he's a smoker, walks with crutches. His x-rays show valgus collapse of the knee with compression on the lateral side. He also has significant patellofemoral arthritis as well. So, Jeff, I was hoping you could take us through these 3 things. This is how every time I talk to the residents, the fellows, the zone of fixation, the type of fixation that you're doing, cemented, cementless, and how you're deciding your level of constraint for this type of case.
Yeah, so I think this is kind of like a pseudo revision, especially on the lateral side like that. I think you have a lot of bone to work with here, and so this is kind of an in-between a primary and a revision workflow for me probably. I'm going to try and do as much as I can with regular implants. I just don't, that second x-ray looks funky to me. I can't tell if it's just a weird angle or what, but
does the BMI change anything for you, the fact that his BMI is 46?
Yeah, I think in revision sometimes it's nice to try to be principled and have the same optimization, but sometimes these patients, infections being the most common reason, right? You can't wait for them to be optimized. This one, I'd love to have some serial films and see how fast this is happening, but if this thing's collapsing pretty quickly, you kind of want to get to it in a reasonable amount of time, and you weren't the one who chose to start the clock on them by doing a uni at a BMI of 46, so I'm probably not gonna wait for them to lose a significant amount of weight with this problem. The smoking, I'm try to be pretty dogmatic about that and get everyone to stop smoking, at least in the perioperative period, but otherwise just normal optimization. So zone of fixation question, I try to get away with a primary tibia on this and then see how the femur goes. I have to see what the balancing is like. Like the posterior condyles here look really funky to me. So I see how it balances with primary stuff, and if you need a little bit more bypass, put a small cemented stem on there. My type of fixation in normal revisions is cones on the tibia pretty much every time, short cemented stems, and then my femoral cone selection is PRN to the amount of rotational control I have with the epiphysis, or sorry, the down at the bottom, zone 1. And then level of constraint as little as possible, right? PS at a minimum usually for revisions, but.
All right, so I guess we're pretty different, you and I, or maybe this was, I think, my first year of practice, so maybe I was a bit more aggressive. I was a bit worried about, because of his BMI being 46, that I really wanted to get some good fixation. On the tibia, you could argue that maybe I could have used primary fixation on the tibia, but what really pushed me is his lateral condyle was pretty wispy on that side, so I felt I needed to back that up, and that sort of drove all my other decisions along there. All right, moving on to Craig. So this is a 56-year-old female, 10 years status post right total knee replacement. BMI is 49. X-rays show loosening of the tibial component with lateral perforation of the tibia. So same questions, zone of fixation.
Yeah, probably no different than what we talked about earlier. This particular case, clinically, are collateral ligaments sufficient?
Clinically?
Yeah.
So clinically, she corrects out and falls in with the valgus stress. She'll correct out. Yes.
Yeah. Okay. So to go back to the flaw, so for zone of fixation here, I think on the tibia, you have you're not going to have much proximal bone. Zone 2 is very big. This is a cone for sure. And then I'm bypassing that lateral area with a longer stem. Cemented or cementless doesn't really matter. I think in a younger person, I may try to do a cementless stem there. For this particular case, I don't recognize that particular implant, but I'd be also prepared to remove the femur as well. And that's a lot of varus, and she's a big person. So I think really, for me, the integrity of the lateral collateral ligament is important. If it's not intact, then you have to just do a hinge.
Okay.
And I know that that's not great in a young person, but You know, what else isn't great is 3 years later, her, having instability again with well-fixed revision components.
Yeah. So I had the same sort of thoughts. We needed to bypass that side on the tibia. To get my zone 2 fixation, I used a sleeve on the proximal aspect, and then I backed up the femur as well, again, given her high BMI on that side.
Yeah, if I can add, on this one side, I think that it's very important she's morbidly obese, and she's going to impinge in the back, I mean, at 90, 100 degrees. So one thing, because I have had a couple of these that actually jumped the post. One patient fell, one patient just jumped the post. And even like they can bring a hinge. So I think that it's important to put the joint line lower. So really try to bring the joint line lower and really try to flex the femoral component as much as you can. I mean, I prefer that these patients end up with 90 degrees of flexion than that they jump the post. So it's very, very important to recreate the joint line to avoid jumping on the post.
All right.
Can I ask you a question? What is the size of the poly of that one? It's probably the biggest one, right?
The size of?
The poly?
The size of the poly in this one?
It's 20-something, right?
It's probably in the 20s, yeah, for this patient here, yeah.
Yeah, so in those, same thing. So I think that you really have to try to make an effort to maybe put augments, if anything, maybe 10, 15 augments to bring the joint line down.
Okay, but in the sense that if the flexion gap is balanced, you're not as concerned. So this is yours. This is a 72-year-old female. Status was bilateral knee replacement in 2004. She's got 16 years with left knee pain, a normal BMI. X-rays show osteolysis and the polyethylene wear. Same questions.
Same principles. I mean, it seems in this one, just because of that defect on the femur, I want to be sure that there is no PJI. So I definitely
ruled out. There's nothing red herrings here. No PJI. This is
okay,
aseptic
so this
loosening.
is aseptic loosening.
Yeah.
I mean, the tibia looks straightforward. I don't have any concerns. And the femur, maybe there may be a defect on the lateral side. You see that it seems that the femur is collapsing there. I mean, it's really no big difference of what you have already shown.
Okay. So for this one, I wasn't confident in zone 1, so I obtained zone 2 and 3 in this one as well. And then down to Claudio. This is a 77-year-old female with knee pain, 10-year status post knee replacement. She's got 3 weeks of knee pain on the right side. You can see that she had a fracture on the lateral side there. The chronicity was not really, we couldn't really determine, but it definitely looked a little old based off of her history and her presentation.
Yeah, I would say the same. The 3-zone fixation is what probably everybody's doing, and I would do the same for the tibia here. I would do a cemented stem in the tibia. In the femur, as you said, there is a non-union of the lateral femoral condyle. There might be a massive non-contained defect. I would use not a sleeve, a cone, because it was the way I feel more comfortable. But I think you can be prepared with that defect on the lateral femoral condyle to have a hinge in place if you cannot balance it.
If you're not happy because of the balance, because you're worried about the lateral condyle?
Correct.
Is this the type of patient that you'd be thinking about a distal femur, or not really?
No.
Okay.
I mean, if something goes wrong in the OR, probably you should.
And then for the lateral condyle, any fixation for that, or you're just going to leave it alone?
No, I would leave it alone.
Okay, yeah, I agree. I went with she was too small to put in a cone on the femur side, and then you could see I did try putting in a sleeve on the femoral side, and then we had a little fracture there, so then I put some cables on the side. All right, so now moving on to something a bit more interesting. Now we got all the panelists in here. So this is a 67-year-old male, 2-year status post left toe knee replacement, complicated by a popliteal artery injury at an outside hospital. So you can see those clips back there. He's unhappy with pain and stiffness in his knee. He has arthrofibrosis. His range of motion is 20 to 70 degrees. He's failed conservative management, including a radiofrequency ablation. So I guess the things that I was hoping to hear first, let's start again, I guess, back with Jeff. Decision for surgery for these type of arthrofibrotic patients, range of motion 20 to 70.
Yeah. So ideally, you find a reason they got arthrofibrotic, some technical issue or something like that you know you can fix. It's the ones where you can't find a reason that they got stiff, where you're going to be a little bit more conservative with just pulling the trigger right away. This patient had a vascular injury. They might have been held up in terms of what they were allowed to do right off the bat. There's a lot of reasons why this one might have gotten stiff in the early rehab. So I think it's reasonable to offer revision to these patients when they don't have a functional range, and a functional range for most people is about 10 to 100-ish. So anything outside of that, with this guy with a flexion contracture of 20 and only being able to bend to 70, I think it's very reasonable to consider revision.
Yeah.
But you got to talk this guy through all the possible problems that can happen, especially with the prior vascular injury. That's the thing that probably makes me the most nervous.
But the vascular injury also was what made you think that he might have a chance of success, right? Because they were
Correct.
probably slowing him down to protect the vascular.
Correct.
Okay.
Correct. In terms of how I tackle these, I'm almost always revising everything in an arthrofibrotic just to get all the debridement done. And then my exposure is almost always a quad SNP. I try to minimize the number of TTOs. I think I've done like 5 in practice. What else? Pre-op radiation. I don't radiate anybody. Oh, do you want to go down? Sure.
All right. Craig, do you have any thoughts on like the preoperative stuff for these types of patients, radiation, medicines?
No, I don't really do any pre-op radiation. I'm not certain that that's really supported too much. It's something that you can do. But I think the most important thing for these arthrofibrotic patients is, unfortunately, spending time with them. I very rarely would offer them surgery on the first visit. Like Jeff said, he may have a reason for, getting stiff, but I think they need to be counseled extensively, because you can look at full 2-component revision, arthroscopic, open lysis of adhesions, you name it, the results are terrible.
Yeah.
Right? And so they got to get buy-in. You have to, they have to
See them a couple of
trust you.
times.
You got to
Definitely
see them
in the
a couple
clinic.
times.
Don't indicate them when they come to your office and say, "Oh, I'm really unhappy."
Yeah.
Okay. Carlos, any further thoughts on the medicines beforehand?
No, we give them, we do more perioperative dexamethasone, more aggressive with the perioperative dexamethasone, 10 milligrams before incision, 10 milligrams after. We usually keep these patients at least one night in the hospital. This one's, we're having a lot of issues with CPM machines afterwards, so we're using the RUM, I forgot the name, but the bicycle. No, we don't have that many. The real question is what type of implants will you use, because now there is good literature that is showing that a good predictor of better range of motion. Well, so I believe it's your group, the radiation, right?
No, the radiation was, I think it was from Colorado, but the radiation study was.
It seems that they have better results using radiation. I don't have experience with that, but the other thing that is important on this one is that you have to release the collaterals. So basically, almost like it's automatically a hinge. So, but then it's always a decision, and I have some patients of mine that I did that, and still I didn't get really good results.
Yeah. You did mention the steroids, though, intraoperatively. Are you doing the steroids postoperatively? Because that paper also did talk about postoperative oral steroids.
I don't send them with oral. Well, I do a medral dose pack. I don't do prednisone, just medral dose pack.
Immediately post-op 0?
Immediately.
Okay.
Post-op 0, and then some COX inhibitor.
Okay.
For
Indomethacin?
at least 2 or 3 weeks. Usually Celebrex, if they don't have a sulfa allergy, they tolerate it better than the indomethacin.
Okay. And then,
But the data shows, I mean, the Knee Society randomized trials show that there is no difference using COX-2, COX-1 inhibitors.
COX-2, indomethacin, we can.
Or steroids make no difference.
And then for the duration, 3 weeks.
Yeah, about 3 weeks.
3 weeks. Okay.
I think I would add that every time we see an arthrofibrotic patients, we always thought about what kind of technical aspects we can improve. And if you look at the overstaff this guy has is massive. I was telling Carlos that I've seen this in the old days when patient-specific instrumentation was popular, and you can see that sort of huge posterior condylar offset, and also the anterior part of the femoral component, it was never flashed to the bone. So it seems like it was a technical thing. Also, the joint line seems to be very distal in the femur. those are probably things that can be improved mechanically. I don't know if they will have an impact at all, but it's something that you should consider.
So when you're going in, you're also going to go after that patella?
That's a very good question. You should measure it. You will never know the answer whether or not it's better for the patient to remove that uncemented component and create a mess in there, right?
So this is what I did. Intraoperatively, we got him out to 0 to 110. At 3 months, he's 0 to 100. He's like, Doc, you're amazing. You're my hero. And I guess saw him like 2 months ago, and boom, 20 to 70, right back where he started, unfortunately. So I think we still have some work to do on arthrofibrosis.
The only other medicine I'm
Yeah.
actually reviewing an article right now on is the angiotensin blockers, ARBs.
Yeah.
There's some literature out there. It's sort of mixed, but losartan, I probably wouldn't feel comfortable prescribing that for patients.
Yeah, that came, I think, also out of the COVID literature. Some of the antivirals were shown to have lower fibrotic rates. So some people are experimenting with that as well. But the only real studies that I've seen, I did start doing radiation. For this patient, I didn't do radiation beforehand. But since that other study came out, I've been doing radiation preoperatively. Can't really say it's made a difference, except the patient complained that we burned her before and after the surgery. So moving on to this, Derek put up a case of extensive bone loss. I would challenge Derek that this is extensive bone loss. So this is a 73-year-old female. She's 27 years status post left total knee replacement. She had a recent episode of left calf pain at the hospital. They got x-rays of her knee, x-rays of her ankle, but no one got x-rays of her, of her whole tib fib, and so she had that fibular fracture there. So, who on the panel would like to tackle this one first with the zone of fixation?
I'll start because I literally just showed Chance a similar X-ray. I'm going to leave the other thing, but I think one thing you need to be concerned about in this catastrophic failure is you're going to get in there and it's going to look like motor oil. That poly's gone. There's probably the case I showed him that the entire tibia, about 2/3 of it was actually rubbed away. Mm-hmm. And so I think preoperatively, you got to talk with this patient about a very, very high risk of infection. And even, we were assuming this is non-infectious, right?
No, there's no red herrings here. Everything has been ruled out for infection.
I may even do this
CRP,
staged.
Staged?
I may.
Tell me what you do in the first stage.
Spacer.
Oh, okay. So you're so concerned about infection, you don't care. Okay.
If you get in there and it's motor oil, the likelihood of infection in my hands is, I would say, it's probably 50% chance that person's going to get infected, and you just spent all this time, fixing, your proximal tibial defect and things like that. So I think that in these catastrophic failures, doing them staged, you don't really burn a bridge. We just heard, all day today how functional these spacers are and can be. For those of us that are involved in our quality departments, an infection hurts.
Gotcha.
Hurts the patient too, but.
Is anyone else on the panel staging this?
I think that it will be hard to do a dynamic spacer on this one. It'll be a little bit hard to hold the tibia. You have to build something laterally. You can do a static spacer.
Yeah.
That'll be easy. But I agree with you. I treat it like if it will be infected. So I do a radical debridement, everything else, and then I do use some sort of antimicrobial solution, everything else. I do all my cuts and my trials, I close it, and then I bring new instruments, and I took intraoperative cultures, and then I put the final parts with clean instruments. So almost treat it like a one stage. That's another option, you can do it. And when you do you definitely have to have some sort of metaphyseal fixation, and I will argue that you will have to, in the tibia, you will have to start building distal to proximal, so I probably just do a long stem, because you really have to bypass that defect on the lateral column on the tibia, the lateral tibial plateau. And I think that with that long stem and a metaphyseal fixation, it may be okay. I have to see, really intraoperatively is really the only chance that once you put that tibia in there to see how much it rocks. Mm-hmm. The femur, it doesn't seem that is going to be a big deal. I think that the complex reconstruction here will be the tibia.
Okay. Anyone doing anything about the fibula? This was a conversation I had with my trauma partners.
No.
No.
And then anyone here doing a proximal tibia replacement?
No.
Okay.
That's probably like a bilobed cone, Maybe you stack one distal to it. But, well, shoot, we missed it. The lateral sort of shows that you might have a peripheral, a rim of bone there. The AP is confusing, but I think we just saw, but sorry.
So intraoperatively, the patella button pops off, and there's an eggshell of bone. What are people going to do in that scenario?
Should we actually describe in those all the, even with 3 millimeters of patella, we have been using the trabecular metal patella, but instead of using the suture, we put 1.2 millimeter screws from the mini frag set from Zimmer.
Okay.
And I had a couple that got loose with the suture, so that we started to use the screws, and we haven't had any loosenings with that. And I think that we have a series, we just submitted like almost 30 patients.
So let's say intraoperatively, you were the type of surgeon that you didn't anticipate needing that implant. What would you do
can
then?
still do the Gullwing osteotomy, right?
What's that?
The Gullwing osteotomy. it's
We have it.
prescribed.
We have it there, so we don't have to order it. So we have it.
I was just putting that theoretically out there in case you're someone like me that didn't anticipate this issue and you didn't have that implant available.
Well, you don't have to do anything.
And just leave
You
it.
can let it fly.
Leave it alone?
Yeah.
I try not to, especially if I do a hinge, but you can.
Yeah, I was a little
For many years, that's what I did.
Comes up more often in a two-stage, right? You've done a really good job getting the cement out of the patella the first time, and then you come back and you're left with just an eggshell that has nothing. So
Yeah.
a lot of those I'll just leave. I've tried there's like the Mayo described pouch where you kind of take a bunch of bone graft and make a pouch and try to rebuild the patella. I tried that once or twice. It never really worked. So
Yeah.
I've just been fine leaving them, or it's self-gull wings like Claudio was saying.
I was a little nervous leaving this one because the bone was so thin. I felt like I couldn't really trust the extensor mechanism. So in this case, shout out to Dr. Beanie for mentioning this one to me. I don't think if he's here though, but he did mention this sort of rebar technique, and then I was pretty happy with that. And given the large flexion extension mismatch, we went for a hinge, and then you get your post-op X-rays, and then oops.
Yeah.
Now what?
Yeah, that's how it's going to fail, unfortunately. Just the lateral column is not conducive of good fixation.
Yeah, I think that cement extrusion I would just ignore. Maybe let them know that they can feel it. If they can feel it, then let them know if they're skinny. But if not, I probably wouldn't worry too much. I have one of those too. They did fine.
Yeah, we got the restrictor in the right spot.
Yeah, I mean, I think with your distal mantle, I wouldn't be worried about a peri-prosthetic distal tibia fracture there. I'd probably let it go. But to Carlos's point, I think long-term, this is at risk of failing for lack of, proximal support, but we'll see, right?
I would say that certainly you have a penetration because cement is outside of the bone. And I would rephrase one of my favorite quotes from David Llewellyn. He said, if you're using fluoroscopic guidance in cases like this, you will accept nothing but perfection. But if you're not using it, in PACU, you will accept everything but a disaster.
So yeah, to be determined, given her age and her activity level and how fragile her bone was, I opted, after discussing it with some of my colleagues, I opted to leave this at 3 months out. She's walking on it, but obviously she does feel that cement on that side along there.
So that's an interesting construct, though, right? Because with a cemented stem, is that under a sleeve or is that a?
So this is a cemented stem distally. I felt that her bone just couldn't tolerate a press fit stem. So to get the fixation distally, my aim was for a hybrid fixation. Proximally on that medial side, she actually had a large rim of bone there on the proximal side there where the sleeve had good contact. Laterally, there's not much there, but the majority of what I was getting my fixation was from the diaphyseal engaging stem, a cemented side there. Yeah. So I was pretty disappointed to see that we perfed out that side along there.
These are ones with those uncontained defects where, at least for me, I don't use sleeves that much anyway, but a cone is just easier. You just kind of pot the cone, and then the cone's got some bone growth, maybe a little distal to where that sleeve is currently, and then you can just cement through it. You don't have to worry about like cement getting on your sleeve or all those other things. So
I like that you bring that up. I did actually have the cones available to go after put them more distal. Is that where you'd put your cone, more distal?
for this one, yeah, I
Yeah.
try, and I'd be okay with it not being circumferentially covered, right, as long as you have a little bit of press fit there.
Right. Okay. So moving on to an extensor mechanism case, this is a 66-year-old male with right knee pain after a chronic patellar tendon rupture. His range of motion is 0 to 120 passive, but actively he's 7 to 100. His joint space didn't look so bad, so I did get an MRI showing that there was severe medial and moderate lateral compartment disease. So I guess let's start with Claudio. For your extensor mechanism reconstruction, can you take us a bit through what your thought process is and what you use?
Yeah, unfortunately, this situation, no matter what you use to recreate the patellar tendon, the shortness of the quad tendon will be the issue. And there are many described techniques to give it length, but in arthroplasty, nobody has ever told us what is the best approach. To be honest with you, I don't have an answer for this.
Okay.
I think, you can do a regular synthetic mesh extensor mechanism reconstruction. Sometimes you have to see because the patella won't come, so it's just stuck up there. So some people describe that you can just do just cut where the cartilage is, the patella, or just leave it if there's still cartilage. If it's getting in the way, or when you're trialing the patella is hitting the notch of the femoral component, then you just can do osteotomy. What you should not do is a patellectomy. That's a mistake, because then it gets super thin. The skin gets very thin there, and it can start draining and things like that. So if anything, always leave the shell of the patella, the periosteum of the patella. You always have to leave it. Never do a full patellectomy. I made that mistake before. And then the next question is, given the fact that you have an extensor mechanism reconstruction, if you necessarily, you're going to have a deficit in doing your stand phase in your extensor mechanism, and you may end up compensating a hyperextending. So that's where people say that probably in this case a hinge will do better for that reason, long term. So I actually did one of this with a PS, just with a PS, but I don't have long-term follow-up.
Okay.
But the reconstruction is in this case that you have bone and everything else, put in the mesh and everything else, you have plenty of bone to put it. You can either put it inside the implant or just, I like to do it more distal, because then you create better lever arm. If you put it inside the implant, then the lever arm is shorter. So you don't give too much of an advantage to the quad. I think that if you leave it distal to the joint line, you give a little bit more advantage to the quadricep, whatever muscle is left.
Is anyone doing an allograft?
Why are we replacing this knee?
Oh, we did get an MRI of his knee, showing that there was medial and lateral.
There's no cartilage?
Yeah, there was no cartilage on the
Looks
MRI.
like it.
Yeah, we did do a multiple. To your point, though, I agree with you 100%.
No, we have a bad
don't know if
problem
that's
and we're going to make it worse by putting metal in there?
I don't know if it's standing.
That's a supine x-ray.
No, but you make a valid point. I do agree with you. We did do multiple trials of non-operative management for him.
Yeah,
We did multiple rounds of injections. He did his other side, and he was happy with his other side, which was a normal knee.
Yeah.
And we did get an MRI. So this, to your other point about the arthrofibrotic knee, this is certainly not someone that comes to your office and then you say, good, I'm going to book you for surgery next week. You're going to be fine.
Yeah, okay. Got it.
Anyone doing an allograft, or is everyone doing mesh? Okay.
I've done, I'm not a chronic, but I've been in on some, revisions, complex revisions, and oops, the patellar tendon peels off, or, something happens, and I've used allograft in those settings, like acutely, with some success.
I assume we're talking about like a semitendinosus allograft, not like a full extensor mechanism allograft.
Usually like an Achilles allograft with
Okay.
a bone block. But in a chronic setting, no, I think it's pretty clear that mesh reconstruction is probably the best of what we have. Again, the results aren't great.
Okay. Level of constraint?
See, that's a funny one because I agree with Carlos that, I think the literature would support when we're revising a knee with a chronic extensor mechanism problem, it's easy. We take out the implants and put in a hinge. Man, that's a lot of bone to take away for a hinge in a native knee. So I may give it a go with like a PS knee or
Seems
something.
like a skinny guy, like
Yeah.
almost
Yeah.
no muscle, at least in the X-rays.
Yeah, he's like a BMI 25, 26-ish. He's not very overweight.
I think that setting expectations from the get-go is super important. I mean, I tell them he cannot compare his total knee with his neighbor that has no problem, so
Yeah.
he may have some.
Or with his other side that he actually has done. Yeah.
At this one, unfortunately, every time that I do an extensor mechanism, you have to immobilize them. It's almost.
Can you tell us how you mobilize them? Do you trust them with a
Yeah,
brace?
so
Do you
I don't
cast?
I don't do cast anymore because I have some issues and I don't have a cast tech and I don't have time to change the cast in my office. So I put him in a brace, in a hinge brace. It's not as good as the cast, and some people are not compliant, but that's what I have been using. And basically the first 6 weeks, no range of motion, and then after 6 weeks, I start. Believe I open it from 0 to 20, just
At 6
active
weeks.
range of motion, no passive.
At 6 weeks.
At 6 weeks.
Okay.
That's
Is
fast.
everyone else
Yeah.
6 weeks?
I'm 12.
12.
We're usually around 2 months. We start slowly bending them like 30 degrees for 2 weeks, then 60. But it's active and it's not when weight bearing, so it's only with
Okay.
the therapist.
Yeah, Menegini has published a little bit more aggressive. I just
Okay.
do a little bit more aggressive, 2 weeks faster.
So I think you make a great point about the paddlectomy, about worrying about the skin on the anterior aspect of the skin there. We did actually use a Kerecis graft to increase the thickness of that area on the anterior aspect of the skin along there. You can see that my trough in the front was not very good. It's sort of the mesh kicked back my implant there, kicked the posterior tilt a little bit more.
How did he do?
Extensor lag, he was non-compliant with the brace. That's why I wanted to really discuss the casting. I was like, maybe I should have casted him. He came into my office at 4 weeks without his knee immobilizer on, and I wonder
So
if I
if
really
you
should
look
have cast him.
at the Mayo Clinic series, which is one of the biggest, the largest one, the ones that do not have a patella, almost all of them, they have an extensor lag. So it may be regardless, because again, you don't have the lever arm of the patella and the quad. So I think that this one's maybe if you put it a little bit farther from the joint line, maybe
okay.
give a little bit of a mechanical advantage to whatever quad is left.
Yeah, that's a great point.
We also published about this in the original article from Emerson of extensor mechanism allograft. He claimed that it fails when the extensor lag is more than 30 degrees. So actually, if you're having less than 30 degrees, you cannot say that technically it's a failure because we know they behave like that. So it's part of the scenario that you will face.
Yeah, I think Carlos brings up a good point about the realities of our practice setups. So we can all sit here and look at articles and say casting is better, this and that, but for the residents or fellows in the room, we talk a lot in our fellowship about, well, what do you have? Like, I'm not changing a cast when we're seeing 45 patients in clinic, right?
Yeah.
So it's unfortunate, but yeah, you put them in a brace and you tell them and you're like hoping that they're going to do the right thing, and most of them do not, but
But the casts are also not benign.
it's not
Oh
benign.
yeah, no, you
We
can
were-
have
we were doing
heel
casting for a
ulcers,
while.
skin
Yeah.
ulcers.
It's like a 75% heel ulcer rate, and they're always obese patient. And this one's not, but usually the extensor mechanisms in the total knees they're obese or they're unhealthy. Like that's how the tissue, fell apart in the first place. So casting those is not fun, even when there is a cast tech to do it. So we've kind of switched to braces too.
Yeah. Well, it's 3:57. I did have a infected case, but I think for the sake of time, to make sure that we get to the happy hour,
Sure,
or do you want to go one more?
it's up to you. Yeah.
All right. So this is we can do.
Dr. Ward, what do you think?
Yeah, I think I have one more.
All right.
The reception starts at 4:15.
Okay. So this is a 85-year-old female. She's a status post explant replant, and then she's got. She status post-explant replant. She's got a recurrent PJI. She's minimally ambulatory. So I guess we can bring it all together now. Maybe Claudio, you want to take us through your revision exposure for this type of case?
Yeah, I always do quad SNP to begin with these difficult cases, and I move from there. I try to avoid tibial tubercle osteotomy as much as possible, but it's been proved to be a safe approach even in infected cases. So if you have to do it, you have to do it.
Okay.
So just for the sake of discussion here, why is she complaining of?
Oh, she has a large posterior, essentially, her skin is tenting posteriorly as opposed to the front. You can't actually see it on the x-ray, but when we went into the surgery intraoperatively, about 250 cc's of frank pus came out from her entire knee. Okay. So her main complaint here was actually the back of her knee. She felt like something was coming out. And the skin.
But she didn't have a sinus tract.
No,
she was very close to developing a sinus tract, very, very close.
Okay. In these cases, every time that I have a fail two-stage, I do what I tried to mention earlier. I do a staging. So all these patients then cross-sectional imaging, because I really want to know where the pus is. If they have osteomyelitis. What did I miss? And that has helped me a lot. It really guides the approach. I mean, again, if you see pus all the way in the back, if you have cross-section imaging, I mean, sometimes you have to do an extensile approach, even posteriorly, because if you leave anything behind, it's going to fail again. So that's one thing that I have done in this one, more than the technical aspects that we already discussed. So stage your infection, try to identify where is it coming from, why is it getting infected again, is it something with the host, is it still smoking, is uncontrolled diabetes, is it immunosuppressed, is it malnourished, all those things. I mean, you really have to, more than anything else, because technically this, I mean, if you just show me the x-rays, it's like, there's nothing wrong with it. So I prefer to optimize it, everything else, really prepare her to surgery rather than rushing her into the surgery and just make the same mistake again.
How old was this patient?
85.
Yeah, I'm washing this out all day, every day. I'm not taking that out.
Yeah, I think that's reasonable, right? Depending on what the organism is. If it's a sensitive staph species or strep species, maybe a washout, chronic suppression, depending upon her other medical conditions and what medicine she's on. I think we up here are fortunate, maybe in private practice a little bit harder, but I have 4 orthopedic-specific infectious disease doctors at our shop, and we have a monthly meeting where we review all of these cases and really tackle it as a team. So yeah, certainly talking about that as an option. And I also, if she's already failed it once, I bring up amputation almost every single first visit with these people too, that's always an option for you.
Yeah, that's a great point. I definitely did bring up amputation with her. The other backstory with her is that she had an infected other side as well that underwent an explant replant.
So there's something wrong with the host. I mean,
yeah, she's chronic kidney disease. She's got a lot of medical issues, lives in a nursing home, and not...
So even with more reason, because you already know if you're going to expose her to a huge surgery that is very likely to fail, it's probably better just to be conservative and just suppress her for life.
We wrote about this when I was a fellow, kind of these extensive implants, taking them out, it's not a 99% reimplantation rate. A lot of them go on to fusions or amputations, and the outcomes are actually better in these big constructs when you just wash it out in the midterm. So I would wash this one 2-3 times even in someone that sick, rather than try to get all that stuff out and then have to.
That's a good point that we haven't talked about, and I didn't put it in my talk. I think that she will be a perfect candidate for a double dare.
Yeah.
I mean, utilizing what had been described for the Mayo Arizona group, have a really good success rate just with that technique. I mean, that's more for acute infections, not necessarily for chronics, but double dare may be a good one on this one.
Sure. Does the posterior skin change anyone's thoughts? The posterior skin sort of was on its way to developing a sinus tract.
Not really.
No.
I mean, you will go, and whatever needs to be excised needs to be excised. If you need a flap, you need a flap. It is hard in the back.
Yeah. It was in the popliteal fossa, yeah.
And even sometimes those that the soft tissues are in really bad shape, you go, you do your debridement, maybe put a vac, let it rest, let it heal, then go back and do it again and see whatever is still viable, and then do the closure.
But I mean, sure, right, Ellie, I mean, there's a lot of patients walking around with chronic draining wounds that we don't even know about. So I think Carlos's first question was the most important, is what is this person complaining of? How can we help her symptoms?
And what is the goal?
And what is her goal? Yeah, exactly.
And actually, I don't dislike when they develop the chronic sinus, because that's their drain. And then they're draining, and we do wound care, but I already know that there is no fluid accumulating there. So actually, those that have a draining sinus, when it's only one, because then some of them, they start just getting those get infected with additional bacteria, and they get that's a different situation. But I have some that they only have one some sinus, like same thing, 85 Staph aureus or Staph epi that is responsive to chronic suppression. I just chronic suppress it. Let them drain.
Okay. So we put her on, actually, these are all great points. We put her on some oral antibiotics to see if that would calm things down.
What was the bug? What was the bacteria?
After her, with the aspiration?
Yeah. That's right.
I don't remember.
Just make it up.
Yeah.
VRE.
I don't want to make it up. I really want to say that it was culture negative, but I mean, you draw out like 15 cc's of frank pus. I mean, how often, you get that?
Yeah.
So conversation with her, we did the oral antibiotics for a while. Her knee, the posterior aspect, just kept sort of getting more and more tenuous. First thing I was proposing to her was to potentially just do the antibiotic suppression. That wasn't working. Then after that, I was talking with her about amputation. That was my first thought, frankly. But because the last couple of times we took this particular patient to surgery, each time she had a very complicated postoperative course. So I felt that if I was going to take her to the operating room, I pretty much only had one shot to take her there. And after her surgery with me, she was in the ICU for about 7 days intubated. So she was very delicate health. I had mentally prepared her for a static spacer because I wasn't confident in terms of how much bone would be left afterwards. She did not like the idea of that, so I told her I would do my best. And in this case, that was my best. What about the cables? Or I guess we can start off with what my decision process. What does the panel think?
I think you did everything. I mean, you counsel. I have a question. I mean, maybe for the panel. You mentioned what you thought was in her best interest, and she didn't like it. So, ethically and conceptually speaking, here, what is our level of? I don't know what the right word to use is, but when patients tell us what to do. Is that appropriate?
No.
You know what I mean? We sort of sometimes lose our own ethical values, and she's like, I don't want a static spacer. Well, you know what? That's what you're going to get. But instead, we try something else. Right. I don't know. Sometimes we forget about our own values, right?
I've been in that specific question that you are bringing up, where I've had other chronically infected patients that they failed the explant replant, and then they needed another static spacer. And I explained to them, I'm sorry, there's no other option left for you.
Yeah.
In this case, she's in a wheelchair for most of the time, so I felt, even though this was not a stable construct, I'll be frank, it was not a stable construct for my, I was really pushing the limits of a articulating spacer. But
yeah, but if she doesn't walk and ultimately her posterior mass went away, and I probably would have removed the cables, but
yeah,
I would have, but.
Yeah, she probably has osteomyelitis in that femur too. But in this case, it's just a savage procedure. I mean, that's the reality. I think that there's, those are just tough. But a lot of times, I think in these cases, less is more. That's what I have learned over the years.
Sure.
Now, it's very, very aggressive. I think that still, as you mentioned, that doesn't necessarily mean that your outcomes are going to be better. I mean, I'm talking about these failures. When it's the first time, absolutely. You have to be very radical. I mean, that's your only chance that you have to control it well. But with this ones, there's clearly something wrong with her. So less is more, as you just
Right,
said.
the host factors are
Yeah,
something
the host
that you have to
factors,
take
so-
into account, absolutely.
Yeah.
All right, well,
How'd she do? She doing all right?
she's back in her nursing home. She hasn't had any recurrence of her drainage or anything like that. The wound healed okay with the IV antibiotics. And then I really had to push the ID docs to keep her on oral suppression because I just felt like it was going to happen again. And most people were like, no, we don't need it anymore. But I'm like, no, she has to have this for life.
So I can tell you on
That's a win.
that,
Great
because
job.
my ID docs, they just don't do it. I do it. I keep doing chronic suppression.
Yeah.
I mean, I talk with the guys in Ohio, and then I ask them what's the best chronic
Yeah.
suppression, then I do it myself.
Yeah. What about for primaries? Just oral suppression, just out of curiosity, since we're talking about oral antibiotics.
So like extended oral
Yeah.
prophylaxis?
Yeah, we have a,
I'll quickly give, I tried to do it the right way at my institution, Meningitis papers and all the papers that are coming out now. So I asked our ID team, I gave them
yeah, there was
the
an AUKUS
papers.
paper recently, not so fast.
And even the infection prevention person, I said, here's the literature, you tell me. And they didn't think it was very robust, and they told me no.
Yeah.
But I'm going to take the opportunity to ask Carlos, because they also publish their study. Correct me if I'm wrong, Carlos, but you guys use doxycycline in your study. Meneghini use
Ceftior.
It's all over the
Cefast-
place.
Yeah.
Ceftior, yeah.
Bactrim. I use Bactrim because theoretically it covers MRSA, but we don't have a clue, right?
Yeah, I think that the overall message with that is just be very cautious. I mean, because the easiest thing is just to have the trigger response and just give extended oral antibiotics to all the high-risk patients. But we don't have data. That's the truth. But I personally think that that's a mistake. I mean, you just have to be very conservative with that approach. The large data that the recent studies that we have just shows that it doesn't really have a difference. Once you do adjustment for all the other variables, it doesn't have a difference. That's what we're starting to see.
Please.
Sometimes it's helpful to, they have primary doctors or hospitalists or people around at the nursing homes, and I would probably communicate with them, because what happens is I caught endocarditis on my patient who I knew didn't have a murmur, and she had diabetes and she had osteo in her knee or foot a few years ago, and she ended up I caught the endocarditis with just my stethoscope. And so you could always, I'm just friendly reminder, we're here to know our patient also, and you can always get them to.
Don't just focus
keep an
only
eye-
on the knee. Look
Yeah,
at the whole
don't,
big picture.
not just that, but know that they do have other doctors to scoop up, because it helps a lot to communicate and just call the doc really quick and say, keep an eye on them. It's kind of like, residency. Hey, let's pass the baton.
Yeah, I think that's a really great point. The most recent PGI I had was from a chronic colitis, and it was only the ID and medicine doctors that caught it, and the patient had to get a colectomy before we did their replant. So,
For the panel, I'm just curious how you've incorporated genicular nerve ablations, both for, say, pain after revision knee, or even for treatment of primary arthritis, which my understanding of the literature, ablations do even better for that than, say, after soft tissue pain after revision. Just for you all, if you had experience with that, how often do you use it? Like for that extensor mechanism case, that's kind of what I was thinking I would try first, but just curious your experience.
Yeah, I've used it. It's only when I don't have anything else to offer. Usually it's kind of a last resort. I think most of the data on is very mixed. We talked about placebo with injections before. I think there's a lot of placebo in that procedure. It's like 5 injections and then doing it all over again to burn. So yeah, it's like 50% at best in the reported studies. So that's probably about what I get, is 50% of them say it maybe helped a little. Has it ever been a game changer? No. But it's offering them something, and realistically, that's why I do it, is I feel like I'm doing something for them.
Yeah, it's the same for me. In addition to that, I have been using it in primaries that have history of sympathetic dystrophy or complex regional pain. Instead of doing a catheter with with the nerve block. I'm using genicular nerves preoperatively, and it's easier. I don't have to deal with the catheter and anesthesia, and I think it has helped me.
Is that the lateral geniculate or the posterior capsule or both for yours?
So we are doing, I mean, what the scope iovera. So you do it all around in the front, and you can do it like a week prior to surgery.
Well, I guess from our, oh, go ahead, Craig.
Nothing different. I mean, I think a lot of us, I probably see 5 to 10 people, probably 5 people a week for a second opinion with painful total knees. And if there's not something wrong with it, which is oftentimes the case, I send them to my pain docs quite a bit. I can't fix them with my hands operatively. They maybe had surgery for the wrong reason. I don't know how they do because they don't come back.
Yeah.
But for my patients after revision and stuff, same thing. It's something you can do. It's something you can offer.
It helps.
Yeah.
All right. Well, thank you to the panel. Thanks for everyone to participating, and we'll see everyone at the cocktail hour.
All right.